Thank you all for getting up and getting in early today to this morning's Leaders in Lagniappe speaker series. This has been a very popular series, but quite impressed by the turnout at 9 a.m. I was already kind of pre-apologizing for what I thought would be a small turnout, but we did good. Today we're welcoming public health we welcome public health leaders to share their innovations, ideas, and leadership values that got them to where they are today. I'm your host, Thomas LaVeist, Dean of the Celia Weatherhead School of Public Health and Tropical Medicine. I hope you all know who I am by now. The origins of this lecture series come from the school's-wide desire to give our students the tools and experiences needed to become the next wave of innovative leaders. And we need that today more now than ever. Through these opportunities to meet and learn from some of the most distinguished leaders in public health, we aim to build a bridge between our future leaders and our current ones. This lecture series also boasts something distinctly New Orleanian, lagniappe, a concept that you'll find throughout South Louisiana. It's the idea of adding a little something extra or unexpected to an occasion. We have adopted this concept of lagniappe by incorporating the arts into the public health lecture series. Our current exhibition, Into the Ball Gallery, Operation Dream, is a group exhibition of local artists and organizations providing insights to the past by reflecting on the legacy of Hurricane Katrina 20 years ago this year, while looking towards the future, to what they hope New Orleans will be in the next 20 years. I encourage you to take a look at the exhibition after this lecture while waiting in line to purchase our guest lecturer's book. Speaking of our guest lecturer, let me provide a brief introduction. Dr. Tom Frieden is President and CEO of Resolve to Save Lives. Dr. Frieden served as Director of the Centers for Disease Control and Prevention and Commissioner of the New York City Health Department. His work made New York City's tuberculosis control program and overall health department models for the world, established effective programs in India, and improved morale, effectiveness, and impact at the Centers for Disease Control and Prevention. Dr. Tom Frieden's influential publications have identified the what, how, and why of action to improve health. As Dr. Frieden founded Resolve to Save Lives in 2017 to partner with more than 60 countries to address the world's deadliest health threats. In the organization's first 8 years, these efforts have supported actions that will prevent 9 million deaths. Dr. Frieden's book, The Formula for Better Health, How to Save Millions of Lives, Including Your Own, distills 4 decades of public health leadership into a clear, actionable framework to extend healthy lives. Drawing from real-world successes and failures, the book bridges the lethal gap between the scientific knowledge and life-saving action. Thank you for being with us today, Dr. Frieden. I'll turn it over to you to tell us more about your book.
Thanks very much. I'm going to talk about the formula for better health. It really is an approach that has been proven to save millions of lives. It holds, I think, the key for how we can make much more progress in our communities, in our country, in the world, and as individuals. And I have to say, all proceeds from the book go for programs and organizations that Resolve to Save Lives works with around the world. The formula is see, believe, create. Those are the 3 steps, and I'm going to talk us through them. But first, I want to tell you a little bit about myself. The strongest influence on my life was my father, a cardiologist, man of very few words, a doctor's doctor. Whenever a doctor had a problem, they went to him. And I was very close to him. He had Parkinson's disease, sadly, and we were hiking in the Blue Ridge Mountains of Virginia. And I remember it was a beautiful day, and he said, in this beautiful day, beautiful outdoors, I can almost feel like I don't have Parkinson's. And as we were talking, he says, you seem to like policy issues, and you seem to like science. You put those 2 things together, that's what public health is. I'd never heard the term public health before. A few years later, I was applying for MD, MPH programs, and I spoke with someone, I don't still know who it was, actually, I don't remember who it was, at Hopkins. And they said something to me that made a big impact. They said, if you want to work in global health, because I knew I wanted to work in global health, you need to become an expert in something that's relevant so that you can bring very specialized skills. It was just a kind of an offhand comment, but it guided my career. I ended up working on tuberculosis control in the US, first documenting multi-drug resistant TB in New York City, then being appointed director of tuberculosis control, and then going to India for 5 years on tuberculosis control. In my time in India, the World Trade Center attack happened at the end of that 5-year period, and I was asked to come back to be health commissioner under Mayor Michael Bloomberg. My father's health at that point was fading. He was in a nursing home. He was speaking less and less. And I went to see him, and I said, Dad, I'm going to be health commissioner. And he understood. And I said, I want to be the best health commissioner. Not that I'm competitive or anything. And he said, in what were actually the last words he ever spoke to me, how would you know? It's a great question. And it introduces the C part of see, believe, create. Public health has a superpower. We can see things that are invisible. We can make apparent trends, toxins, microbes that kill people. And by making them apparent, we can confront and reverse those risks. The superpower of surveillance was discovered in 1662 by a cloth merchant in London. Until I did the research for this book, I had never read John Graunt's treatise on mortality. It is amazing. It is the first time in any society anywhere in the world someone looked at rates and proportions, infant mortality rate, maternal mortality rate. He showed emerging diseases. The emerging disease was rickets, vitamin D deficiency, probably because coal was being used more. And so there was more clouds, fewer sun exposure, more vitamin D deficiency. For whatever reason, rickets increased dramatically from 1633 to 1660. He also hypothesized that coal might not be so healthy, seemed to be associated with death rates. He also showed the economic implications of different diseases. Plague, he documented for the first time, plague accounted for between 1% and 82% of deaths in different years. And he saw that epidemic fever, we don't know what that was, but epidemic fever was much more economically disruptive than plague, because although plague had a higher case fatality ratio, epidemic fever had a much higher prevalence, leaving, he said, scarce hands enough to bring in the harvest. And he had a really important insight, and one that we can still learn from. He asked, okay, what one number would you use to assess the healthfulness of a community? And he suggested it's the risk of dying under the age of 70. He said, if any community has a lower proportion or a higher proportion than we do of people living to 70, they're healthier than we are. In his day, it was 7% of people. In the US today, it's 70%. Don't think that sounds good. That's 30%, nearly a third of Americans die before reaching age 70, most of them from causes we can prevent. The healthiest communities in the world, countries in the world, are about 80%, and it really should be 100%. Ideally, there should be no deaths under 70, or at least very few. Now, when I became New York City Health Commissioner, I had been working in India for 5 years, really immersed in tuberculosis. Tuberculosis was, I literally breathed tuberculosis. I'm tuberculin positive. But when I was asked to consider becoming health commissioner, being an epidemiologist, I downloaded the vital statistics report from New York City, looked at SAMIC, and said, wow, they haven't stopped smoking here. You know, that's their #1 cause of death. There's no reason for me to come back to New York City unless this guy who I'd never heard of, Mike Bloomberg, is willing to take on tobacco. When I met with him, he had got that message. He started the interview conversation with 10 minutes of what a big problem tobacco was and how we needed to take it on. So he knew how to recruit people. We first made cigarettes more expensive because taxation is the single most important thing you could do to reduce tobacco use. It was a big fight. The state really runs things, not the city. And so the state had to approve, and they basically extracted half of all of the tax revenues for some crazy reason. But it went through. And because surveillance is so important, seeing the invisible, one of the very first things I had done was to implement a community health survey that could track rates of risk factors in New York City. It was basically a BRFSS for New York City. Had never been done before. So we didn't have data about baselines. We could kind of put it together by taking statewide data and lumping 3 years together. And we knew that the tobacco use rate had been 22% for 10 years. And we did a baseline survey, and it was still 22%. We implemented the tax. Really, really gratifying. Tobacco use came down dramatically the next year. That year, we implemented smoke-free policies. Every bar and restaurant in New York City smoke-free. Next year, came down again. Really gratifying. So seeing the invisible, we wouldn't have known that there was 22%. We wouldn't have known that these two policies worked. And I thought we'd done enough. But the next year came back, and there was no further decrease in tobacco use. In fact, it went up slightly. So seeing the invisible isn't just about trends. It's also about programs. Because the road to hell is paved with good intentions. And you can think you're doing a great job, but if you have data, you can know whether or not you're actually making a difference. And the data showed we weren't. We were failing. And it was scary. This was my #1 priority, and we were failing. So we looked at all of the data. We couldn't raise the tax again. The state wouldn't do it. The CDC recommended, based on their review of the evidence, running hard-hitting anti-tobacco ads for about $1 per capita. That's almost $10 million for New York City. $10 million is enough to run clinics, hire staff, do lots of other things. It was a bet. So we ran $10 million of ads targeting the communities that we knew had the highest rates of smoking. And in the next year, because we had the community health survey, we could see that those ads worked. So we could defend the program. So seeing the invisible is about seeing toxins, trends, microbes. It's also about seeing whether programs are succeeding or failing. It's also about seeing why we're blind. Cassandra was a priestess in Greek mythology. She was blessed with the ability to see the future, but cursed that nobody would believe her and heed her warnings. So the terrible tragedies she foresaw, with blood running down the walls of Troy, would come to pass. She went crazy because of that, right? All of us would. And yet, public health has been like Cassandra. We can tell you, I can tell you, 1 billion people will die from tobacco in the world in this century, unless urgent action is taken. But how do we motivate people to change? And why does that Cassandra curse exist? Half of smokers, if they don't quit, will be killed by tobacco. If every smoker knew that after their next cigarette, they had a 50-50 chance of dropping dead, not a lot of people would smoke. Part of the reason for the Cassandra curse is that our perceptions are inaccurate. Our perceptions of ourselves, our perceptions of the world, and our perceptions of the future. When I ran the CDC, I visited the tobacco lab at CDC. The tobacco lab at CDC had ordered a smoking machine. They actually make these things. A smoking machine that could use a clamp to smoke a cigarette and measure the different chemicals that smokers were inhaling. When they tried to buy that machine, the tobacco industry tried to block the sale. And in the years that followed, the scientists running that lab figured out why the tobacco industry was so adamant that they didn't want the CDC to have that machine. First thing they noticed is that that clamp that held the cigarettes, that's not the way people smoke. People cover the filter. And there were lots of tiny holes in the filter. So when the clamp was there, a lot of side stream air came in from the room and diluted the carcinogens and other chemicals in the cigarettes, allowing the industry to brag about safer cigarettes, which was nonsense. They were no safer. But that was just the beginning. They realized that the tobacco industry made sure that there's more nicotine at the tip than at the base of the cigarette. That's why smokers stub out their cigarette halfway down and light another one. They need another hit of nicotine. But that was just the beginning. They also realized that the tobacco industry had put urea, that's urine basically, or other alkaline chemicals into the tobacco because it potentiates absorption of nicotine in the lung and gives you free nicotine or free-base nicotine. And they added menthol, which doesn't just smooth the flavor, it appears to increase the number of nicotine receptors in the brain. With those engineering changes, a puff of a cigarette gives your brain faster, more active nicotine than an injection of nicotine in the vein. Smokers may think, oh, this is my self-control, I'm not, but we don't really see the influences on our behavior because the industry has changed it. Our perceptions of reality are not so accurate, like our perceptions of the future, like the smokers not quitting. So to see the invisible means we have to see the trends, the toxins, the microbes. We also have to see the path to progress. And I've discussed the path to progress some in things I've written, like the public health impact pyramid that you may have seen. But I go into that in a little more detail in the book because saying follow the science is a really bad term. The science doesn't tell you what to do. The science says, based on what we know now, if you do this, you will get that. That may be a question of policy decision or a clinical decision or another decision, but technical rigor is a very complicated topic. And doing really good data analysis is extremely important and extremely hard. It is really an art, not just a science. There is a misconception that randomized controlled trials are the gold standard. They're not. They are fantastic for some uses. I'm a tuberculosis doctor, and the first RCTs were done in tuberculosis. And the TB worldwide, collaborated to do a series of RCTs that showed exactly how to treat tuberculosis patients. That's a great use of RCTs. But you couldn't do an RCT to study tobacco taxes or smoke-free laws. And so you need to be able to see the pathway to progress using technical rigor. And that's what a lot of the training and the research and the experience has to be. But seeing the invisible, that's easy enough. We have that superpower, got that, check. How about believing the impossible? All too often, what seems inevitable, in fact, can be changed. And that's particularly a problem for groups that have been historically disadvantaged, where it may seem that there isn't possibility of progress. To believe that change is possible, I think three things make a big difference. The first is to show how much progress there has been. And it's really quite remarkable. If you look at tobacco use in the US, because we started with some tobacco examples, in 1965, 46% of Americans smoked. By 2005, that had been cut in half to 22%, and last year was at 11%. So we're looking at a 75% reduction. Even more dramatic, when I was an epidemic intelligence service officer in 1990, one of my fellow officers did the study that showed that more 6-year-olds could recognize Joe Camel than Mickey Mouse. And 36% of teens smoked. Last year, it was less than 2%. Now, recognizing past progress doesn't mean we say mission accomplished, everything's fine. And I think we in public health are often reluctant to recognize past progress for that reason. Hans Rosling's beautiful book, Factfulness, talks about how we have a hard time with two distinct concepts, that things can be better but bad, bad but better. I think that recognizing past progress should give us the momentum and motivation to want to make more progress. But the next way to strengthen belief in the possibility of progress is to make more progress. Phased progress. Phased progress is very important. It's something I learned in tuberculosis work. It's something that we at Resolve to Save Lives do. We have what we call a solutions pathway, where we identify what are the biggest problems that are high burden, high amenability. Then we prototype different solutions to see if they work. Then we prove concept by trying them in different places. Then we scale them up and sustain them. And that solutions pathway is a very important concept. Pilot projects are problematic because they spread a very dangerous disease called pilotitis that they never spread. It's very hard if you're putting extensive effort into an area. Is it actually the kind of thing that can spread to an entire community? And if not, it may do a great deal of good for some small group, but it's not going to scale. Phased progress allows you to scale something. It might be part of a city, all of a city, all of a state, all of the country. It might be part of one community, but you want to start in a couple of places. You want to start with good leaders. You want to adapt it to the local community. You want to make sure it fits the needs and see if it works. And the final part of strengthening belief in the possibility of progress is optimism. Now, I know that these days it may be hard to keep optimistic. And in fact, it may seem delusional to be optimistic. But I do think if we step back, we have better tools, better diagnostics, better treatments, better vaccines than ever before in human history. We have new tools, including artificial intelligence, which, though problematic in some ways, has transformational potential in health. So I think we can make a lot more progress. I've been very fortunate to have some wonderful mentors, one of whom has been Dr. Bill Foege. Dr. Foege led the eradication of smallpox. His book, House on Fire, is a wonderful book about public health. And he was working in India doing everything, renting jeeps, vaccinating kids, briefing politicians, hiring staff, training doctors. And people asked him, what's your job description here? And he said, resident con man. My job is to keep people believing we can do this. But it wasn't a con. There was a good technical package, that technical rigor, that see the path to progress. There was a good technical package for smallpox eradication. Surveillance and containment, ring vaccination, active case finding, very clear way forward. And with that optimism and that technical package, seeing the path to progress, smallpox led the burden times amenability calculation, millions of deaths a year, and could be zero. But people had to believe it was possible. With that confidence, more than 200,000 healthcare workers in more than 70 countries found more than 10 million contacts of patients with smallpox and vaccinated them against smallpox within 5 days of exposure and eradicated smallpox forever, saving billions of dollars and millions of lives. Dr. Foege was then asked, after the eradication of smallpox, what next? And he said, the eradication of bad management. And that's the third part of the formula, see, believe, create. Because it's hard enough to see the invisible and believe that what seems inevitable can be changed. But the really hard part is to work together to create a healthier future. But there is a way to do it. There's a systematic approach. It starts with getting organized. Organization and prioritization is enormously important. Every time you make one priority, you make a bunch of enemies, basically, because it's hard to prioritize some things and not others. But it's extremely, extremely important to prioritize, because if you don't do that, you won't make the progress you need to make. But even if you organize and prioritize, you won't succeed unless you simplify. one of the core moments of my career happened when I was running the New York City tuberculosis program, and a doctor named Carol Stieblo came to visit. And he looked at all of our data, and he said, Dr. Frieden, this data shows me a lot of interesting things, but it doesn't show me the most important thing. I was kind of offended. I said, what's that? He said, well, last year your program diagnosed 3,811 patients. I said, yeah? How many did your program cure? And I didn't know, and I was really ashamed. And the next day, I started a program to track the outcome of every single patient in every single part of the city, every single quarter. And with that, we were able to stop the tuberculosis outbreak in New York City, the largest outbreak of multi-drug resistant tuberculosis that this country has ever seen. So simplification is very important. Leonardo da Vinci wrote in something that Steve Jobs copied, that simplicity is the ultimate sophistication. But even if you're organized and even if you simplify, you'll still fail unless you communicate well. And communication is not something about programs. Communication is part of programs. I'll tell you the story of Terry Hall. When I became CDC director, we had learned from that experience in New York City that hard-hitting anti-tobacco ads worked. We had some resources. I said, let's run them nationally. So we came up with the Tips from Former Smokers campaign, rigorously documented to be very effective. And we looked for Americans who were willing to tell their story. And Terry Hall was one of them. She had been a cheerleader in high school, and she had worked on a tobacco farm. And she had started smoking 2 packs a day. She developed cancer in her 40s. And she recorded a series of ads, including one that she insisted we tape the day before she died to warn others about the harms of tobacco. And what we had learned from New York City is that what really motivates people to quit is disability and disfigurement. Not death, because you're dead, and not being healthier. And I know there are some studies that suggest that those ads would be better. They're wrong. The ads are really, the data is really clear. When people see disability and disfigurement, they're motivated to quit. So Terry Hall, as a communication strategy, she prevented more deaths than most doctors will in their lifetime. So communication is enormously important and was probably the biggest failure in the COVID pandemic response. But even if you simplify, and even if you organize, and even if you communicate well, you'll still fail. Why? Because See, Believe, Create ends with that overcoming barriers. The Cassandra curse that I talked about earlier stems, among other drivers, from something called the prevention paradox, which you may have read about from Jeffrey Rose, which shows that the biggest changes in society happen because of small changes for lots of people rather than big changes for a few people. Very interesting epidemiologic concept, yet it's got a political corollary. And the political corollary is that there are a few groups, self-interested groups, that are going to vigorously oppose progress, and the people who benefit from that progress are many, but they only benefit a little, what the economists call concentrated costs and diffuse benefits. The people who will benefit may not have even been born yet if you remove a toxin or control a disease. Now, when we were trying to make New York City smoke-free, it was a big fight. It was a really big fight. And we had to overcome the concentrated opposition of a few bar owners and restaurants because millions of Americans, millions of New Yorkers would be healthier. In order to overcome the barriers that public health will always face, we need to look at who wins, who loses. Who are the deciders? Who are the influencers? Who are the advocates who can make a difference? What are the partnerships that can make a difference? What's the timing that makes sense? And what are the pragmatic approaches to progress? In the first hearing in front of City Council, which had to approve the Smoke-Free Air Act of New York City, we had 4 people on the panel: me, the health commissioner, Mayor Michael Bloomberg, Dr. Harold Varmus, Nobel laureate and head of Memorial Sloan Kettering Hospital, and Martina Payne Yehuda, a pregnant waitress. And the city council told me years later, you know, the three of you, nothing. But we had no answer for her. How could we force her to keep going to work for something that could make her child ill or not reach their potential, just so some could smoke at her workplace? So finding the right advocates can make an enormous difference. Now, public health has done great things in the past, but there may be this lurking suspicion that we can't do great things in the future. And I think that with the formula, we can see the harms, see the economic drivers behind some of those harms, see why we may be having difficulty making progress, see the rigorously proven pathway to progress, strengthen belief in the possibility of progress, and then work together to rigorously, systematically, effectively overcome the barriers so that we can implement well-organized, simple, well-communicated programs that can save millions more lives. Thank you very much.
Thank you so much for that. And thank you for coming again this morning. So I have a few questions I want to ask you that are, a couple of them are standard questions. I told you that this is a lecture series that we give all the time. Then a couple of questions that sort of stem from your remarks this morning, and then I'll open it up to the audience and give them an opportunity to question you. So first, I'd like to ask if you could give advice to any of our students about about to enter the workforce. What would that advice be?
Well, I think obviously this is a difficult time for hiring in public health. And the most I can advise students is same I advise my own kids, which is remember that you're building something. You're building yourself. You're building your capacity to do things. And I think three are particularly important. One of them is the ability to look at data rigorously and carefully. And you know, if you want to just listen to I listened to just a couple of podcasts, but I'll just mention one. As we happen to be here in New Orleans, it's the American Heart Association national meetings. There's a podcast called Cardiology, This Week in Cardiology by John Mandrola. I've never met him, but he epitomizes to me what I talk about in chapter 3 of the book of technical rigor, that he knows the studies so well that every new study that comes out, just listen, it's 25 minutes, listen to 1 week, you get a sense of, oh, if I just read the abstract, I would have thought this. But having had someone who really knows the data well, I know that. Well, each of us needs to become that sharp in our specific area to really look through data. Look, AI is doing amazing things, but it's not going to think for us yet. And to really understand deeply what it takes to analyze data, that's a crucial skill to learn. Second is the ability to communicate, to say something clearly, to communicate on video, as is now 40% of people are getting their news through YouTube. So we need to learn to do that in public health. So communication is extremely important, whether that's writing academic articles, writing grant requests, writing an email, but communication or listening well, because communication starts with listening well. So data, communication, and the third is implementation, learning how to actually get stuff done. And for there, I think there's a lot of potential.
Yeah. Yeah. And how do we teach that in classes, in our classes? How do we teach our students how to get things done?
So data, I think you can go deeply into different areas and help students learn that. Communication, I know of one school that does what we did at the Epidemic Intelligence Service course. It's very painful. They had a one-day course where you are given a situation and you have to give a mock press conference and answer questions, and they tape you. And then everyone watches the tape and critiques you, and then you have to do it again. It's really painful. Nobody likes to see themselves like that. Well, very few people like to see themselves like that. But you have to learn and practice, right?
That's diabolical enough that we may actually consider bringing that into our curriculum. So I'm really curious about something you said. You talked about communications during the COVID pandemic. Talk to me about that. What was your critique of that?
Yeah, well, yeah, in chapter 7 of the book, I talk about what the CDC has recommended traditionally. Be first, be right, be empathetic, give people practical things to do, and that in 2020, the first Trump administration violated every one of those principles like completely. They didn't just ignore them. They did the exact opposite. But I don't think the Biden administration was blameless on this. By insisting that the CDC speak from the White House, they really condemned the CDC to having a lower credibility among people who hadn't voted for President Biden. And it was not going to be effective to ask, look, to do good communication, you need the right message and the right messenger. The right messenger to tell Republicans who weren't getting vaccinated wasn't President Biden, right? Or anyone associated with President Biden. So I think these were two big mistakes.
Mhm. Interesting. I could go on that topic for hours, believe me. So first, do we have a microphone? So how are we going to handle this? You're going to bring the mics to the people? All right, because I want to give the audience the maximum amount of time to ask the questions. So you talked a bit about your time in New York as health commissioner, which was really interesting. But I really wanted to talk to you about. I mean, you did mention the big gulp controversy, which I really
Which one?
big gulp.
Not after my time.
Oh, that wasn't your.
I actually did not. I rejected that idea
All right.
when it came to me because
Okay.
this was, for those who don't know, this was limiting the size of sodas. I just didn't feel you could win the court of public opinion on that.
Mhm.
It was Tom Farley, yes.
Well, yeah.
We're good friends. We just emailed this morning. So Tom is a great guy, but we don't agree on everything. I brought Tom in as my main advisor. And so he was behind a lot of the initiatives that we did. But I didn't agree with that one.
Oh, okay. I'll have to ask him about it. So talk about the cigarettes though. You did work on that, and that requires something that I spend more of my time doing than I wish, which was talking to policymakers, right? Which is critical if you want to move public health forward. How were you able to move the audience on that, the political audience?
It's very interesting. So advocates can be really important. There's a guy named Joe Cherner, discuss him some in the book. He came to the book party that we had last month in New York. Joe had been a bond trader, had made enough money to retire at age 30, and was an anti-tobacco advocate. And he had written to every candidate for every citywide office, asking them to fill out a survey. Do you support smoke-free, bars, restaurants, beaches, public, whatever, and asked them to sign it by hand, and then he posted them on the internet. And so we knew that we had the mayor, who was, absolutely rock solid for this, and we had many of the members of city council. We handled it, frankly, as a political campaign. We came up with a tagline that was simple: secondhand smoke kills. That was our tagline. We just came back to that with everything. We addressed concerns on economics, on employment, on the restaurants. We pre-bunked things. My favorite press conference of all time was the day before the law went into effect, we had a bunch of bartenders, waitresses, all together saying how much better their lives would be. And we had the media all there because it was very high profile. And we said, we had the data because we're health departments, or see the invisible. We had the data that there are 23,000 restaurants in New York City, and on an average day, 5 to 7 will go out of business. On an average day for every year, because it's a tough industry, right? So I said, listen, as of tomorrow, the industry is going to tell you that these are because of the Smoke-Free Air Act. We will tell you each month how many went out of business because we got that data. And if it's increasing, we'll tell you. But until there's an increase, don't say they're going out of business because of smoke-free, because it's a misinformation. And in fact, employment and restaurants did better. Turns out that people don't like to eat where it smells like an ashtray.
Yeah, but it seems to me that one of the biggest challenges we're facing now is this individual rights and freedom versus putting restrictions on those freedoms, and that's one of the biggest challenges that we're facing in public health. I would imagine that would have been a
That was a
major.
big issue. That was a
Yeah.
big issue. And we threaded that needle in a couple of ways.
Mhm.
Your right to swing your fist doesn't extend to my nose. And your right to smoke a cigarette doesn't extend to my lungs. I'm not telling you not to smoke. Just
Mhm.
don't smoke in my workplace. We did polling, and we realized that the one line that would work was it's my bar, I get to set the rules. So we actually had an exception in the New York City law for an owner-operated bar that had no employees other than family members. Because like we couldn't win that argument, right? The state banned that anyway, which was fine. There were like 3 of them in New York City. So there were ways to deal with that. Now remember, it's a very different thing to mandate a company to stop polluting or an employer to stop making their workers sick versus mandating someone to do something themselves for their own good.
Mhm.
And I think that's where we got the COVID mandates wrong. Because once it became clear that COVID vaccination primarily protects you, not primarily other people, then it became more like a motorcycle helmet mandate. And that's very controversial. You need to do that at the community level. It's not like a measles vaccine where you need to get it or the kid down the street with leukemia may die from measles. So it's a very different dynamic. The other thing that was a huge challenge was um, there was a push to allow separate smoking rooms in the bars. And that was a hard one because what the data shows is if you allow a separate space, the health benefits are minimal. Smokers don't quit because they can smoke there. Employees aren't safer. And once you've built a separate smoking room and sunk that money in, they're very hard to get out.
Mm.
So the head of city council had probably taken money from people to ensure that there would be separate smoking rooms. And I felt so discouraged. And I know one of your questions here was, what would I tell a former me
Mhm.
from what I know now? And it would be, don't get discouraged. Don't get discouraged. There's always a way forward. So in this, I mean, I really thought, just as I thought when I talked about how the prevalence of smoking stalled, I really thought we had failed at our top priority, but we were able to get it resumed. Here, I mean, I had spent like every moment I could spare for the better part of a year trying to get this law through, and now it was going to fail. It was really depressing. And then Joe Turner came up with an idea, the same guy who had sent that survey. He said, he knew, I didn't go into the technical term, one of the drivers of the Cassandra curse, chapter 2, is hyperbolic discounting, that we shortchange the future. And I go into that there. So Joe kind of understood that intuitively. And he said, look, what you do is, you let them build it, but you ban them after a few years. And no one will build it because they'll realize that this doesn't make sense for them. And make it hard to build. And that comment of his, make it hard to build, that triggered something in me. I said, oh, I know how to make something hard to build. I'm a tuberculosis doc. We write specifications for tuberculosis isolation rooms. You have to have 6 air changes. You have to monitor that the airflow is negative with respect to the rest of the building. You have to you have to exhaust your air at least 6 feet from any other air intake. So that's what we put into the bill. So yeah, you can have a separate smoking room, no problem. But it has to have separate smoke, all of these specifications, and they have to be approved by the health department, and you have to close it in 3 years. So 2 places saw, can we do this? And when they heard the requirements, forget it.
I'm surprised those requirements passed in the law, and you wouldn't have to put them in the regulations, the regs. That's
Well, there
yeah.
were both law and regulations. New
Mm.
York City is a little different from most other places because the city council has a lot of authority.
Mhm.
It's exempted from statewide rules,
Wow.
and the city health department has regulatory authority.
Wow.
So the Board of Health is a regulatory agency actually, and it's run by the health
Mm.
department.
Yeah, very different than New Orleans. Any questions from the audience? got one in the back there. Yeah, the state preempts the city.
Yeah.
Essentially.
Yeah.
Hi. You were discussing this maybe a little bit in the last question, but I'd be interested. What the value of health is obviously one that we hold, but there are other values too, right? And it came up a few times in your talk that I thought. But for instance, you talked about people fear disfigurement and disability, right? A lot of us would say we should be trying to reduce stigma around disability and disfigurement, right? Maybe we shouldn't be leaning into bad parts of human psyche, right? Do we want to lean into, I don't know, sexism or racism as motivating factors, even though that might be effective? And I just wonder if you want to talk about sort of conflicts of values and that sort.
Sure. I mean, what we were doing in the tobacco work was reducing the number of smokers to reduce cancer and heart disease. And we were using rigorous evidence to say what would actually succeed at doing that. And we were using the stories of real Americans who wanted to share their story to help others not go through the suffering that they had experienced. I think there is an interesting kind of tension. I knew someone who was doing a thesis on this, on the disability rights movement and the preventive movements. And at what level are you saying, that this is life is less than? So these are complicated issues, I think. I think when you began speaking, I thought you were talking about the broader issue of beyond health. And this has been a critique of the public health response to COVID. If people don't have jobs, but they didn't get an infection that they would have recovered from, that's not a win, right? So I think we do have to look at things as a community generally. And with effective communication, what's important is to listen first, to understand what are people seeing, what are they believing, and then to work in an evidence-based way to craft a message and identify messengers who are going to be effective at delivering that message. But public health makes progress by having specific goals and achieving them. And sometimes goals, can be in conflict with other goals, but you always want to try to do that in as respectful a way as possible.
Okay. Everyone back here.
Right. Thank you, Dr. Tom. So my question is, you've spoken extensively about the danger and destructiveness of traditional smoking. How does this differ from e-cigarettes? Thank you.
E-cigarettes are something of a complicated issue. In some countries, they're much more regulated than in the US, so that they can't have flavors, they can't have more than a certain amount of nicotine that's delivered. I think that the story is complicated with e-cigarettes. There are certainly some people adults, for whom use of e-cigarettes either enables them to cut down or quit tobacco use, and that's a good thing. There are also many kids who start with e-cigarettes and then progress to regular cigarettes, and that's a very bad thing. So as with many industries, what's important is how it's regulated. And is it regulated in a way that promotes health? Can you take those concentrated interests of the sellers of e-cigarettes and the diffuse benefits of all of our kids who may be less likely to get addicted to nicotine, and balance that? I think it's really tough. In an ideal world, and we do not live, as all of us know, in an ideal world, but in an ideal world, we would regulate cigarettes so that there's non-addictive levels of nicotine in traditional cigarettes. And then we could deregulate other forms of nicotine delivery, because nicotine itself is not very harmful and has some actually positive behavioral and potentially other consequences.
Mm-hmm. Okay, thank you. There's a question here. Is there another question? And maybe we can get the microphone to the next speaker so we can kind of keep it moving.
Thank you so much, Dr. Frieden, for an excellent talk. I'm very inspired. It's a hard time for public health, as you mentioned. How do we get the public's respect back in a public now that doesn't believe evidence-based information?
Yeah, a few things there. One, public health needs to um, listen well, communicate well, act faster when there are problems, expand partnerships, and deliver results that people can see, whether it's shorter outbreaks, cleaner food, water, air, specific programs. I think we need in those partnerships to include primary health care. There's been too much of a divide between health and public health, and we need to try to bridge that divide. It's in everybody's interest. Primary care deals with stuff that they wouldn't have to deal with if public health were succeeding, and public health can benefit from primary care delivering more effectively. I think primary care can be a bipartisan, nonpartisan issue. 100 million Americans lack primary care. We spend $4.5 trillion. It would be really hard to spend more money than the US spends on healthcare and get worse health outcomes. In fact, no country in the world does it. So I think partnerships are going to be very important to regain trust. I also think we should not overstate the problem. I'm not saying that you did, but I think we sometimes can get a little discouraged. 90% of parents still get their kids fully vaccinated, right? So the loudest is not always the most representative. But I think we in public health need to get much better at pre-bunking things before they happen and debunking them in understandable ways as soon as they happen.
Thank you, Dr. Frieden. I had a question about how you use the techniques that you mentioned to motivate folks. You know, one of the things that we focus on in the school a lot is health inequities. And it's really hard to convince folks who are not on the receiving end of those inequities why they should vote for new policies or new taxes to help those. And, you know, we can see what's happening with SNAP, for example. How do you use what you had mentioned about motivating people in a way that's effective in order to convince them that, you know, there should be more greater good?
One thing that sometimes works is to just talk about efficiency. 14% of Americans are Black. 28% of deaths to people under the age of 65 from heart disease are among Black Americans. So if we want our money to get as much done as possible, we have to have a focus on the populations at greatest risk. So it's an efficiency argument, even if there is an equity aspect as well. I also think personal stories make a really big difference. Individuals can really help. When I was TB controller for New York City, we fought for years to get money to get the clinics renovated. Then Mayor Dinkins lost to Rudy Giuliani, and we were really afraid we'd lose the renovations. In the first week of the Giuliani administration, a letter was sent from the New York Coalition to Eliminate Tuberculosis, demanding that the clinic renovations proceed. That letter kind of sifted down from the mayor's office to the health commissioner to the deputy commissioner to my desk. I didn't know what to say. I wrote a kind of a mealy-mouthed reply. It went back up, deputy commissioner, commissioner, deputy mayor. Deputy mayor, no, we're going to renovate those clinics. So that letter actually saved clinics that have treated tens of thousands of people in the years since. The letter was written on a manual typewriter by a person by the name of Charles Ehlers, who was a cured tuberculosis patient. And the New York Coalition to Eliminate Tuberculosis was Charles Ehlers. So individuals really can make a difference.
Okay, I think we have time for one more.
Hi. Hi. I agree. Thank you so much. What an inspiring talk. I was curious about your thoughts on some of the other issues that we face in public health that are similar in regards to the smoking and tobacco issue. Our school leads research on gun violence and violence on abortion policy and some of these other politically contentious things. And we've been talking a little bit here on how do we get ahead of this and find common ground with those who, especially being in the South and the Gulf South, right? And And so if you think about Jonathan Haidt's moral matrix, and how do we resonate with the public who are distributed, their values and their ideas and beliefs are distributed all across that matrix. So I was wondering if you had any just sort of take home lessons learned in terms of how we kind of change the water.
Yeah, it's hard, right? I mean, it's been said that politics is the art of the possible, and public health is also the art of the possible. And what you're seeing is the confluence of concentrated interests and the ability to spread information or misinformation very quickly, very widely for not much money. And so if you look at the issue of gun violence, there's a broad consensus, 70% approval ratings for some very sensible policies, but they're very hard to get through. So there, I think Cities Against Gun Violence and other groups have been doing, or communities against gun violence have been doing important work, but things are going to have to take time in some of these ways. I'll maybe end with a comment about this, that a generation or two ago, it was completely normal for a family to hop in their car, not put on seatbelts, drive to the beach, put on tanning lotion, not sunblock, have a few beers or more, hop back into the car, drive to a restaurant, smoke in the restaurant, have a few more drinks, and drive home. That was normal. That was a social norm. That social norm has changed. There's still too much drinking and driving, too much smoking, too much skin cancer, but it's no longer considered acceptable. It's no longer considered the norm. Advocates against drunk driving had to work for decades to change that, but they did, because facts are stubborn things. And even if they're twisted or ignored or suppressed or cherry-picked, they're still fact. And one of the facts is that people want to live a long and healthy life. And if we can empower them to see what's really causing harms, believe that they can change, and work together, we can create a healthier future. Thank you.
Okay, thank you. A big thank you to Dr. Frieden for joining us today. And I invite you to join me and Dr. Frieden in the Duval Gallery, where the Tulane Bookstore has set up some copies of Dr. Frieden's new book. Dr. Frieden has agreed to stick around for about 30 minutes to sign some copies as well. Thank you so much for joining us this morning, and we'll see you in the gallery.